And we're live.
Hello and welcome to today's seminar on the response to COVID-19 in South Asia. I am Chelsea Farrell, the Assistant Director of the Lakshmi Mittal and Family South Asia Institute at Harvard University. The mission of the Institute is to engage through interdisciplinary research to advance and deepen the understanding of critical issues relevant to South Asia and its relationship with the world. As part of this engagement, the Institute is running a series this spring on a number of topics related to COVID-19. We're so glad you joined us today, and please consider joining us for the next week's seminar as well. Before we get started, we have a couple of housekeeping items for today. During the question and answer session, you can submit questions directly to moderators via the Q&A function on Zoom. Due to the large number of attendees at today's seminar, we unfortunately will not be able to cover all questions. There will be a short survey automatically sent to you at the end of the session. We would ask that you kindly fill this out. Finally, today's session will be recorded. Without further ado, I'd like to introduce the moderator of today's panel, Dr. Vikram Patel. Dr. Patel is the Pershing Square Professor of Global Health at Harvard Medical School and holds honorary professorial appointments at the Harvard Chan School of Public Health and the London School of Hygiene and Tropical Medicine. His work has focused on child development, adolescent health, and mental health in India for over 2 decades. He is moderating this call from his home in Goa, India. Thank you for being with us today, Dr. Patel.
Thank you very much, Chelsea. And let me first of all start by welcoming all of you to this webinar. I would like to particularly thank our 4 panelists who I'll introduce in a moment. But before I introduce them, I wanted to give some context and background about the purpose of the seminar and what we hope to achieve during the next 1.5 hours. Friends, I think we all know that the lives of billions of people around the world have been completely upended by the COVID-19 virus, not only by the impact of the infection directly on lives lost, but also as a result of the policies that have sought to control its spread, particularly the policies that have sought to control its spread through shutting down, to various degrees, social and economic life in countries. Nowhere is this more true than in South Asia, where more than 1 billion people have now been under a lockdown, which according to the University of Oxford, ranks as the most stringent anywhere in the world for 4 weeks now, and possibly at least another couple of weeks ahead. There have been raging debates, both in the region, but also across the world, about the most appropriate way to contain and ultimately defeat this pandemic. And these debates have touched on many issues. It's not possible for us to cover all those issues in this webinar. But instead, what we have decided as a panel is to focus on 3 overriding issues that keep cropping up in these debates. The first is the tension between saving lives and saving livelihoods. Now, some have argued that this is an immoral question because lives must always come before livelihoods. Yet others have argued that it is a meaningless question because lives and livelihoods are inseparable, and that policies must take into account the balance between lives and livelihoods because the loss of livelihoods will directly or indirectly lead to the loss of lives. The second issue is the continuing challenge about testing, about having an accurate count of the numbers of people who are infected. And the real challenge isn't only the numbers of tests that are carried out, but also the kinds of individuals who are being tested. And because there seems to be no standardized protocol to this, there are enormous variations in testing protocols, which means in turn that it is impossible to compare estimates across time and space. As one example, are the much larger numbers of
We seem to have lost Vikram Patel for a moment, so just bear with us as we get him back online.
Hi, Chelsea, am I back on?
We can hear you, Vikram.
Okay, I'm sorry, I got disconnected there briefly. So I was just saying the second challenge is the challenge of numbers. And I think the issue here has been that the variation of the way testing has been done, both in absolute numbers and the kinds of people tested, is that it is almost impossible to compare estimates across time and space. For example, we are told that the numbers of cases in the state of Maharashtra are much higher than the numbers of cases, say, for example, in the northeast of India. But also the absolute number of tests is vastly different between these two regions. Is it that the numbers of cases are simply reflecting the numbers of tests carried out? Related to this, of course, is the other big concern that people have had in the region about the accuracy of some of the earliest mathematical models, whose predictions really, I think, drove a lot of anxiety about the potential impact of this pandemic on lives lost in the region. And I think also perhaps potentially drove some of the policies that followed. The third issue is the way the information about the pandemic has been communicated. For example, the ghoulish reporting of the numbers dead reported each day on the front page of our newspapers and the numbers of cases rising day upon day cumulatively has no nuance really about the epidemiological precision of these numbers or what they actually mean. Or equally, the scary numbers that are being communicated about the numbers dead from rich countries fail to address, for example, the extremely different age structure of those societies or the social circumstances of the dead. For example, very few know that the average age of death in Italy is around 80, and about a third of all the people who've died in Italy died in old age care homes. And I think we can begin to see that generalizing from those numbers to South Asia is extremely difficult, given not only the very small numbers of older people in the region, but also the fact that old age care homes are not part of our landscape. Similarly, the numbers of those people who've died, numbering about 400 in India as of the latest count, it needs to be put in the context of the fact that this constitutes less than 0.1% of all the deaths that have occurred in India since the first case was reported at the end of January. Friends, our goal today is not to do a post-mortem of the policies to date. No, I think the real goal is to be forward-looking. And what we really want to do is to harness the lessons that we've learned over the last many months with a focus on the region, but also drawing on global experience to really think about what should policy look like in the coming weeks. We need to interrogate what has been the impact of the policy so far. We need to look into the future to ask questions about how prepared is the region in order to address what is inevitable, the future surges and clusters of cases that will emerge as the lockdown is lifted, because of course, the lockdown has not eliminated the infection, but it has only stopped transmission while the lockdown is in place. At the same time, we also need to consider how can the lives of those whose livelihoods have been shattered be rebuilt? How can we prevent, for example, the deaths due to hunger and despair that are looming on the horizon? Now, for this very, very ambitious task, we have assembled an amazing, incredible interdisciplinary panel spanning expertise in epidemiology, health policy, public health, anthropology, and economics. And importantly, all our panelists are deeply rooted in South Asia. And indeed, 3 of the 4 panelists, like myself, are in fact joining this webinar from their homes in India and Bangladesh. I'd like to briefly introduce all 4 of them, and then we will turn over to the panel. Each panelist will have about 10 minutes to respond to some questions that I've placed, the issues that I've highlighted, and then we will have a Q&A session between the panelists as well as questions that those of you on the webinar have submitted. So let me start with the introductions. My dear friend Richard Cash is with the Department of Global Health at the Harvard Chan School of Public Health. He's currently at his home in Cambridge, Massachusetts. He has worked on infectious diseases issues in South Asia for over 50 years. Don't be fooled. Richard is a very young man, as you can see on the camera, but he has in fact had expertise for 50 years as a scholar in residence, as a researcher, and as a teacher in the region, much loved by many, many people in the region, and currently directs a course at the Chan School on social, political, and economic dimensions of infectious diseases in low-resource settings, very germane to our conversations today. Professor Srinath Reddy, my mentor in India. Srinath is the president of the Public Health Foundation of India and formerly the head of the Department of Cardiology at the All India Institute of Medical Sciences in New Delhi. He also serves as an adjunct professor of epidemiology at Harvard and at the Rollins School of Public Health at Emory University. Srinath is very well known as the chair of the high-level expert group that drafted the Universal Health Coverage, a framework for India, and is also currently serving on a number of technical committees to inform policy making at state and central levels. Dr. Shamika Ravi is an economist. She's a senior fellow in the Governance Studies program of the Brookings Institution. She's a former member of Prime Minister Modi's Economic Advisory Council. She trained in economics at New York University and is very accomplished in publishing in the field of economics, particularly development economics and economics as applied to healthcare. And finally, Dr. Sabina Rashid has been working since 1993 in a range of different organizations in Bangladesh, including BRAC, the Grameen Trust, and UNICEF. She joined BRAC, the James P. Grant School of Public Health in 2004 and was appointed its dean in 2013. Her expertise is largely in implementation research and advocacy, particularly in the area of reproductive health programs for young women and for adolescents. Right, let me now turn to our first panelist. As I said, we have three broad issues and the panelists are free to address any of those, but also I have some specific questions for each of the panelists that they may choose to respond to in their remarks. Richard, you're living in a country where we now have the largest number of lives lost due to this infection. And interestingly enough, similar to India, there are very raging divisive debates on a number of similar issues. For example, the number of tests that have been carried out, the balance between lives lost and livelihoods lost, and also, I guess, from the particular US perspective, the fragmentation of the response across states. But paradoxically, of course, one of the big complaints that people have in the US, which is the opposite to India, is that the president of the US did not respond quickly enough, even when he should have. And in contrast, in India, of course, people are remarking on how strong and how early the response of the prime minister was. So my question to you really is, what can we learn from the US experience and indeed that of other countries around the world, which can serve to guide what we might be doing in South Asia? And what is your opinion about this controversy around inadequate testing as the bedrock of epidemic containment? Richard, over to you.
Thank you very much, Vikram. Let me cover this in the following way. I'm going to speak a bit about the global pandemic, then the response, and then I will turn to India and put India within that context. I want to emphasize that word context because the epidemic itself and the response is highly affected by the context. We know that this is caused by a coronavirus, SARS-CoV-2. It's a respiratory disease with a R0 of about 2.4. That is, about 2.4 individuals are infected for every case. It plays out differently depending on the demographics. That is, the age structure, the density of the population, the behavior. Of 1,000 infections, not cases, but infections, about 85%, and these are estimates, are either mild or asymptomatic cases. The remainder are clear clinical cases, of which a small percentage, less than 5% of that remaining 15%, are severe and may lead to death. The infection to fatality ratio is estimated as either between 0.3 and 0.7%. That is 3 to 7 deaths per 1,000 infections, not cases, but infections. The incubation period is about 5 days, and from the time of symptoms to death is about 20 days. Now, the response globally has been very, very different depending on context. In Wuhan, in China, which they picked up the epidemic fairly late into the spread of the coronavirus, there was a very severe lockdown which reduced spread, but which reduced what's called a surge, that is the number of severe cases, but it was an afterthought. The places that we should look for a very appropriate response are South Korea and especially Taiwan, where because of their experience with SARS earlier on, 10 years earlier or so, they were geared up to respond very, very aggressively to this particular outbreak. That is, they screened early, they isolated early, and provided care. There was quarantining, there was contact tracing. But this was all done very, very early in the course of the disease. Now, in the United States, it was taken up much later. By the time responses were picked up, the epidemic was already well established. Now, in the United States, there are about 92 people per square mile, or 36 per square kilometer. We'll see the difference when we look at India. The mean age is around 38.5 years. Physical distancing is possible. Many people live in their own homes, but there are some regions, some areas, some communities where there is very, very intense living together. Again, the context, demographics, cultural, government resources, and so on. Now, let's look at the situation in India. Here, the population density is 464 per square kilometer, over almost 5 times greater than the US. In Bangladesh, it's 1,115 people per square kilometer, over almost 11 times more densely populated than in the United States. Mumbai, and this is not looking into the actual intense populations in Mumbai, where there are 70% is considered slum, where there may be 4 or 5 people staying in a room. The median age in India is about 28 years. It's a much younger population, with 28% below the age of 14. In the United States, it's 18%. And above those over 65, in India, it's about 6%. The United States is about 17%. Why do I mention that? Because most of the deaths that have occurred in the older age group. 80% of the deaths in the United States, and this is reflected in many other places, are in the over 65-year age group. Now, what has then been the response? Well, to talk about India as one place, of course, is a fool's errand, because there are many, many cultures and states in India, and a state like Kerala has done a remarkable job in terms of creating messages, physical distancing, and a intervention that is built on over 50 years of social support for their community. That is not the case in much of India, and that is what we are trying to address. So let's take a look at what is possible and what is the situation there. As I noted, the age structure is much younger in India than, and I'm looking now at all of India, although I gave you the example of Kerala, and there are other examples that I could give. But overall, the age structure is much lower. And why is that important? Because for those infections under the age of 14, there is essentially no disease. There have been essentially no deaths in children under 14 years of age, and that's important to recognize. So 30%, almost 30% of India will not experience, even if they are infected, any mortality. The elderly people in India, the 6% most of them are looked after in their home. There are not chronic care facilities, old age homes, and so on. There are in India, but very, very few. Most of the, or many of the deaths, 30%, it's estimated in New York and other places, have been directly related to people living in these extended care facilities. What about this idea that by locking down, that is by keeping people forcibly from physical contact, not social contact, but physical contact, because that's what we're trying to do. This is very difficult because 80 to 90% in India are daily laborers who are not salaried, unlike government employees and so on, who are salaried. These individuals are not. They live on daily wages. What about the whole issue of health care? That is, one of the reasons for lockdown was to reduce the surge of illness. The fact remains is that within India, given their the health infrastructure, the few ICU hospital beds, the limited number of physicians and nurses and respirators and so on, there is not, every day is a surge day within the Indian hospital system. So by preventing a surge, you will not really have accomplished much of anything. The epidemic will continue to spread. It will not be stopped by any type of lockdown situation. The epidemic will continue to spread and will spread maybe a bit faster. What about testing? The issue of testing has been brought up. In Korea, at the height of their testing, they were, in Korea, as a population 1/15 the size of India, they were doing 10,000 a day. India has just announced that they are doing 13,000 a day for a population of 1.3 billion. Widespread testing is not going to go forward and will be useful only in defining small epidemics. Much of the diagnosis in India now and in the future will be through syndromic diagnosis. So the health system, the testing, and so on are all a very, very different level than in Europe or in East Asia. And my strong message is that whatever intervention is planned for the future, because as you noted, Vikram, what is done, must take into account the context that is India, its demography, its age structure, its health infrastructure, its resources, and so on, and should not try to mimic a system where in the US they spend $11,000 per capita in health, and India spends $75 per capita in health. They should not try to mimic this particular intervention strategy, because I do not believe that it is appropriate within the Indian context. So let me stop at that point.
Thank you, Richard. Thank you very much. Thanks so much, Richard. Let me move swiftly on to Srinath. Srinath, I wanted to pick up on a couple of pieces that Richard mentioned as well in your response. One of the curious things in India that you have also written about is the fact that we have, despite a very densely packed population, not seen the kind of spread that one would have feared. And I wonder to what extent that could be also attributed, apart from the age structure of the population, to the early actions that were taken by the government. So while there's been a lot of critiques about the lockdown, I also would like to hear your thoughts about maybe what might have been some of the positive impacts of the lockdown. I'm also curious about the notation that you have also observed that there's been apparently a rising number of cases actually in the last few weeks. Is that a sign of success, that we're doing better case finding? Or how does one interpret those rising numbers? Or is it indeed a sign that perhaps the epidemic was already in place even before the lockdown? And finally, I think something that Richard also spoke to, I'd like to hear your thoughts on this idea of one size fits all. What is your thought about having a single policy for a continental nation like India with such enormous epidemiological and socio-cultural diversity? Srinath, Reddy, over to you.
Thank you, Vikram. Let me start by saying that a decision to have a complete lockdown is never an easy one. Frequently, looking at the global scenario of surging cases, even OECD countries in a state of collapse in terms of their health systems, it becomes a question of damned if you do, damned if you don't. So you still have to take some decisions. There are some negative consequences, very unfortunate in terms of the social and economic impact. And I'm particularly distraught at what has happened to the migrants and what are the problems being faced by the informal workforce. Nevertheless, public health considerations pushed it to the forefront. Now, let me deal with what might have been the positives that we can still take away. Firstly, it does appear from a variety of sources of data that we have actually accomplished the result of slowing down the epidemic in terms of reducing the infection spread rate. And therefore, I think, how do we say that? Firstly, look at it as a triangle. At the top of the triangle are the serious cases getting hospitalized. In the middle of the triangle are cases who are staying at home isolated. And at the bottom of the triangle are the people who may be totally asymptomatic or very minimally asymptomatic. Testing may not be able to get to the bottom of the triangle, but syndromic surveillance of households is taking place in many states, and that's giving you the middle of the triangle. No major caseload there. You're also seeing at the top of the triangle, hospitals not being crowded. There's no big rush for the hospitals, admissions right now at the moment. Therefore, all of this would suggest that there has been some impact in trying to markedly reduce, if not completely disrupt, the chain of transmission. So that is one public health objective that has been achieved. Now, secondly, there have been many other positive outcomes. Firstly, there has been a much greater degree of appreciation overall about the importance of public health and the need to strengthen public health systems. The neglect of the past could possibly be redressed as we go along. There is a much greater element of partnerships emerging, not only of strengthening the public sector, but also mobilizing both the healthcare and non-healthcare sectors of the private sector in order to provide a cohesive response. The private sector is also stepping in now to produce more APIs rather than import from China. They're stepping to produce ventilators, to produce personal protection equipment. And all of that is happening now when the importance of building a strong health system, belatedly though, but nevertheless, is being realized. Then you have a much greater degree of social solidarity that has been mobilized across the people. There is a great deal of citizen participation, particularly in states like Kerala, Andhra Pradesh, and Odisha, and even elsewhere too. Finally, the tone and tenor of the political debate has softened from being a very acerbic nature of conversation to a much more accommodative, unity-focused conversation. And therefore, there is a much greater political unity, which is also reflected in much better center-state coordination. The center and the states are all on one page now. These are all the positives that I believe we should take away. Now, let me come to some of the points that Richard has raised, saying that India should not have followed the same pattern as some of the countries with much older population. But the comorbidities that actually predict adverse outcomes like hypertension, diabetes, chronic respiratory disease, all of them are actually seen at a much younger age in Indian population, at least 10 to 15 in the Western population, and we have a fairly high prevalence of those, especially in urban areas. We also have malnutrition at the younger age groups, even in the reproductive health age group of women, and even in the teenagers. So you have a challenge there. You cannot predict exactly how the virus is going to affect us. Lastly, Richard also mentioned that we have a very poor health system. Yes, we do have a weak health system relative to many of the OECD countries. And that's why we must be extra cautious in preventing a huge surge of cases that can overwhelm us. On one hand, Richard cannot say and should not say that you are not going to have too many cases. On the other hand, say you're going to have a daily surge. Of course, we must be prepared for reducing the surge if we can. And lastly, also the testing business. If we feel that we are at a low risk population, then you should not hold us to account for the testing numbers. Even then, for every 24 case detected, 24 tests have been performed. And I don't think we ought to be looking at testing as the sole mantra that we should be depending upon. If you look, for example, Kerala, which most of you are familiar with, Kerala has achieved excellent success in control, despite a low testing rate compared to international averages. But if you want to go global, look at Bolivia and Belgium, same population, very different testing rates. And the death rate in Bolivia is extraordinarily low. And you have, on the other hand, Belgium, 100-fold higher rate of deaths. Now, therefore, Richard's original point that conditions in each country differ are very important, and you should not apply the same testing logic to India as to other countries. We have to have differentiated approaches in our own context. Now, as far as whether we are actually seeing the spillover of cases, even from the past exposure into the 3 weeks or 4 weeks of the initial lockdown, of course there are bound to be. Given the incubation period of the virus, which can extend up to 14 days, we are going to see, at least in the initial period of the lockdown, some of the cases that are going to spill over. Even when you shut the tap in a garden hose, there is still some water left in the garden hose. But also, remember, the lockdown is never 100% successful. There are slippages. So there will be cases mounting. We are going to see more rising cases. We are still on the ascending limb, but the idea is to reduce the slope and quickly bend it as we can. And we'll see what success we have achieved when the lockdown is finally over. But at the moment, the indicators are suggestive, and Shamika is going to talk more about doubling times. I'm not going to get into that. But all of these actually suggest that we have achieved some public health success as well, apart from all the other benefits I have stated. Now, coming to the question of strategies, certainly we must have differentiated strategies. India is a very large country, and we cannot afford to have a single strategy for the entire country. Yes, at the central level, with consultation and consent from the states, policy must be made in a variety of areas. At the state level, planning must be made for the entire state. But implementation with flexibility, depending upon context-specific realities, must be made at the district level. And that is where we are actually going in now. We are profiling each district. We are looking at the realities of whether the district is hot or warm or cold. And then decentralized decision-making will guide our path forward. And finally, I also actually would like to tell Richard that yes, a lot of our elderly people stay at home. They don't live in old age homes. That is exactly the reason why the lockdown was needed, to give enough time for reducing the virus levels and so that we can deal with it later on. Because if we had actually not imposed it, the young people would have straight away carried it into the homes where joint families are living, and the elderly would have been vulnerable. I think there have been many challenges, and everything is not defensible, but I'm not going to play Monday morning quarterback when the play is still in progress. It is for us to look at the future with a certain degree of hope, plan better, critique where necessary, but I think the final analysis will come up after we have seen the experience when the epidemic starts ebbing, and that is the time for postmortems, not now.
Thank you very much, Srinath. Let me turn to, I think what you and Richard have presented somewhat different perspectives, but I actually think you are speaking from the same hymn book. The question really, I think for us, is not whether or not a lockdown works The question really is, how should it be implemented? In what kind of manner should it be monitored? And most importantly, and I'm hoping each of you are going to comment on as we end, when we end this webinar, is that I like you to prepare. This is a question that I think people are flagging up on the chat box, is that looking forward, what do you think should be the role of strategy with a view towards the freedom of movement of people and the return to social and economic life? This is going to be the closing question. So, but for now, let me turn to Shamika. Shamika, I think one of the most important debates around the lockdown. So we heard from Srinath very much about the public health positive impacts of the lockdown. And I don't think anyone can really question that for sure the lockdown must have reduced transmission by the very nature of the fact that if you're locked into the house, the virus cannot spread to anyone else. The question is really about the balance between the lives that have been clearly saved as a consequence of lockdown and this other counter view that is there in the debate, which is about the loss of livelihood. And is the loss of livelihood also in one way or another affecting mortality? I'd like you to comment on this factor. Do you think, in fact, that this is a meaningful choice, or is it actually something that one has to take both of these into account in this context? For example, someone reminded me that about 2,000 children, according to the global burden of disease data, under the age of 5 die in India of malnutrition every single day, 2,000 a day. Just to put it in context, about 500 people have died of COVID-19 in India since January the 30th. So if one assumes that poverty is related to hunger, which I guess is a rhetorical assumption, then one would assume that the malnutrition-related deaths are going to go up. So what is your view about striking the right balance between saving lives and saving livelihoods in a region where more than 75% of the workforce is in the informal sector with no social security net or very little social security net? Shamika.
Thank you, Vikram. Thank you for the opportunity. Let's start out by basically acknowledging one very big gap in our own understanding, even as experts. A lot of the predictions which were made by the AP models and many AP models were really taking into account the parameters from either early stage China or the Diamond Princess, the cruise ship. And because of that, of course, we saw very alarmist numbers. Right? We were seeing 400 million, someone said 700 million. And those are the kind of early predictions that we were working with in the beginning. And yet we know that, whether it is contact tracing, whether it's the R0, these parameters are not a matter of faith or belief. They have to be estimated for different populations. They can't just be airlifted from one country and apply to another. And in fact, I'd argue in the Indian case, we need these parameters to be estimated at the state level to really make sense out of, a lot of the predictions that have been made. The other issue is also that, based on our understanding, we are also assuming that human beings remain the same throughout, right? And yet we know that, the elasticity of demand for self-protection really rises as the epidemic grows. So even if the lockdown is lifted tomorrow, it's unlikely that we will go about hugging people or shaking hands or moving back into life as we knew it before. And that will not just include ordinary citizens, it will include institutions, firms, and I think also at the policy level, there is a lot of dynamism in the way we respond to the situation. So let me just first start out by just presenting some early numbers, just to give you a sense that moving beyond the AP models, what we said is let's just put out simple statistics for what we know is true for India. Now, this is the, the log scale graph that I think most people are familiar with now because it was made popular by the Financial Times. And here, if you look at the hotspot countries, and I define them as countries with more than 50,000 cases, look where India is. This is the left panel. Our total numbers as of last night, and we update this early morning, is 13,430 cases, right? I mean, it's really very, very small compared to what you're seeing in the big hotspot countries. Look at the total number of deaths. Now, in even Belgium and Netherlands, which actually have fewer cases, have a very large number of deaths. India's death rate, again, extremely low. Now, this is what we have been sort of grappling around. This is a reference also that Srinath made earlier. This is the Indian total confirmed cases growing. What you have to study is the change in the curvature, which tells you the change in the growth rate of the total number of cases. And you know, this is not random. It's quite systematic if you look at the fact that until the 23rd of May, we had a growth rate where we were doubling every 3 days. Of course, there is a base effect, so we're growing fast in the beginning. But from 23rd onwards, what you see is a decline. And you obviously take this back to policies enacted or what happened in India 2 weeks before that. It's important to acknowledge that while the first case of COVID was announced or reported by most countries, the OECD, India, in the last week of January, what you saw is in the Indian case, they airlifted a lot of students from Wuhan, from Iran, from Milan. Many people were quarantined early, very early on, and kept separate from the rest of the population. So very early on, the government started to do and take steps which on a hindsight actually proved to be quite smart. Now, what you observe from the 29th of March is an escalation where the total number of cases started to grow every 4 days. So after initial rise, there was a decline in the growth rate because of the early steps taken. But 29th is when this super spreader, this massive congregation from the Jamaat was discovered. And then very quickly, we realized it has spread to 17 states of the country. And then it started to escalate, the total number. Right? So that's one inflection point. And then where you see the latest inflection, Vikram, is on the 6th of April. From the 6th of April, what you see is a steady decline in the growth rate. Of course, overall numbers are increasing because we are still in the growth phase. But look at the rate at which it is increasing. In fact, as of today, our numbers are doubling every 8 days. Right? So this has been a steady decline. And it's important to take it back to what happened 2 weeks before the 6th of April. And obviously, the national lockdown happened. Now, beyond looking at day-to-day fluctuations, you know, it's important to look at moving averages. So we look at 5-day moving averages. You see that while there is an increase, you know, the increase is very muted. In India, I mean, the 5-day moving averages for new confirmed cases is about 1,100. If you look at daily death, it's about 40 daily death. So again, in the context of the international conversation, India's really, you know, looking pretty okay. If you look at the COVID death rate, very, very low, right? Even in Japan, for instance, after all the early great success, now you see the death rate is actually beginning to rise very rapidly. And so you see that they're going back to declaring national emergency, etc. There was a reference made to Belgium. Belgium lies absolutely at the bottom of this graph, where you see that not only is the death rate very high, but it is still growing. So every country is really witnessing you know, a situation which is very, very contextual and specific to that country. Now here what you see is, you know, China, of course, I mean, it's incredible. They've almost fitted the central limit theorem. I mean, it's like a wonderfully fitted normal distribution. But, you know, if you look at the democracies, look at Germany, South Korea, France, Italy, Spain, it's a slow decline. And there are fluctuations on a day-to-day basis. In fact, you have days when deaths rise and recoveries decline, but on the whole, while it is slow, there is a steady improvement. Now, this is the graph that I really want people to look carefully. This is India for you. It is a very large country. I think this is the 4th time we have said that in this webinar. And that's because there are 28 states, very large states. These are the different states of the country, and I have included graphs from states which have reported at least 150 cases. Look at Maharashtra, still steadily increasing. In fact, the national numbers are largely driven from Maharashtra, and even within Maharashtra, it's really Bombay and the surrounding areas. Delhi has had a couple of massive increases, but it looks like it's, you know, it's on a better path. Tamil Nadu, again, high and flat. But look at Kerala. If you go down on the bottom second row, Kerala looks like it's over the hill. It really has brought it down to under 5 in case of you know, new confirmed cases. Haryana looks like it's you know, crossed the hill. Increasingly, if you look at Telangana and Andhra Pradesh, they seem to have things under control. And yet Maharashtra, Madhya Pradesh, UP, these are states where the increase is pretty high. Remember, while we have a national lockdown, but health is a state subject in India. It's the state administration, the local administration, which determines exactly what are going to be the policies enacted to counter this infection. This is telling you what is the death rate per million across the states of the country. Again, enormous variations. Kerala has 0.06 deaths per million, very low, and it has maintained it at very low position. Uttar Pradesh is low, but it's increasing. Of course, Uttar Pradesh has 235 million people. Kerala has about 35 million people. So again, enormous variations. Delhi and Maharashtra are at the bottom of this, and you can see that not only are the death rates high, but also increasing. Now, this is coming back to this, because overall what we are seeing is with an increase in the number of tests, the total tests, the confirmed cases per 100 tests, they're rising. But you know, they're not rising the way you are seeing the, the growth rate of the total tests are far, far higher, which means that with the conservative testing strategy that the government is following, maintaining this level at around 4.2% means the targeting is perhaps good. And we have, while we still say, we continue saying that we need more testing, but clearly something in the strategy of targeted testing is working, right? Now, this is to tell you, going back to the early question you put to all of us, we are working with so limited, such limited data that it's quite, almost you feel a bit blindfolded when you're really trying to analyze such a complex, a massive crisis, this dynamic phenomenon with limited amount of data. But again, if you look at the Johns Hopkins data, you look at the ECD, look at the WHO data, significant discrepancies, right? ICMR, of course, has, pretty poor reporting protocols. So they're not very regular. They tend to report at different times. They're usually PDFs. Sometimes they forget certain variables. Sometimes they add a variable. So the regularity or the lack of it really makes it difficult to analyze based on that. But the other is, the R naughts, the contact tracing, the parameters based on which we are having this conversation needs to be estimated for the local population, which means you need patient level data. You really need massive surveys happening right now so that we can actually try and understand at the dynamics and the way this epidemic is unfolding in India beyond the national and the state averages. So this is where I sort of want to end my presentation with the sense that, with $2,000 per day, per year per capita income, India is a resource poor economy. We shouldn't forget that when we compare either the stimulus or the testing numbers or just the responses with the OECD countries. And yet we have a national lockdown. The opportunity cost to life and livelihood is enormous because beyond COVID death, there is something called all-cause mortality. When OPDs are shut down for many days, we do know that patients suffer. From the health-seeking aspect as well, access to healthcare. But of course, in terms of the economy, if you look at it, with the 21-day lockdown, the first phase, our estimate, our prediction for GDP growth for this year has come down to 1 to 2%, right? Close to 10 million workers, mainly in the informal sector, have a very serious risk to livelihood. If you look at the non-performing loans in the country, and you do know that the banking sector has been undergoing tremendous stress over the last almost decade, the NPAs are going to rise 4 to 5%. Now, obviously, all of this is weakening the economy further. If the lockdown continues, because now we are in phase 2, and suppose this continues until mid of May, then we're talking about a negative growth rate of -2 to -3%. Now you can imagine for a $2,000 per capita income, what this means for ordinary citizens. Livelihood risk, 40 million people, right? Again, mainly informal. And this is also an underestimate, frankly. NPAs rising to above 10% means the banking sector weakens further. Firms are not able to pay back loans, and it's just a vicious cycle which just becomes worse and worse. So we are arguing that given that the state of the infection is nowhere as severe as it is in the OECD countries, given the preparedness of the country in terms of ramping up health infrastructure, at least fever, clinics and having beds, having protective equipments, etc., mobilized, we are saying that we now need to lift the lockdown, of course, in a calibrated way, which means if it is geographically done, and by the way, right now we have about 325 districts in the country, which are COVID-free. Of course, the only way to tell that is we start to also test for community spread in those places. But, you know, based on the symptoms, we are seeing that a very large part of the country is not affected. 170 districts are hotspots, so the focus needs to continue in those places. But we need to ramp up testing further. We need to continue to measure community spread simply because this lockdown is very expensive. And to make an informed decision on how to lift this lockdown, if it has to be calibrated, then it should be based on the knowledge of the spread of infection. Of course, once we open, then we have to have on-site testing. Punjab, for instance, has declared that, you know, we are going to open our manufacturing firms for all firms which have the capability to do on-site testing and screening of the employees. You're going to see enforced and enhanced new protection protocols, which means firms are going to require for people only to come back if they do not show the symptoms, which means they have to be necessarily tested. So I think, you know, it's important to realize that we know what we know, Vikram. We have certain amount of data. We have to make the best use in terms of informing policy on a day-to-day basis. But it looks like India is nowhere close to the OECD countries as far as the severity of the outbreak itself is concerned. So we need to minimize our costs on the economy front. Thank you.
Thank you, Shamika. Thank you so much. And I want to turn to our last panelist, who represents one of the other very populous countries of the South Asian region. Sabina, I actually would want to really hear from you about your impression about the impact of these policies that have focused on individual behavior on the social structures and particularly the inequities that are very prevalent in South Asia. Is there a differential impact of these policies? And I also want to draw on some of the questions that have been submitted. We've had a bunch of questions coming in, and I thought I'd also perhaps use this opportunity to wrap some of those in. For example, the differential impact on women and girls, which I think is a particular area of your expertise as well. The differential impact on migrant workers. I don't know if you've had the same situation in Bangladesh as we've seen roll out in India. And so really drawing on your understanding of the social stratification of South Asia, how do these focuses on individual behavior impact differentially across the different strata of our society? And really what is happening in Bangladesh, really? If you could also update us all on the current state of policies, and to what extent do you see the level of constriction of the economy being the price that people will have to pay in order to control the spread of the epidemic?
So it's night here, so I think it's good morning in the States, and everywhere else is different timings. I'm a medical anthropologist, so it's been fascinating to listen to the different perspectives. I'm going to speak a little bit from the community perspectives. We've been undertaking some rapid surveys around urban, rural Bangladesh, and also case studies in the slum settlements and amongst the more marginalized groups. One thing that there's a couple of three areas that I want to cover is the structure of how we understand disease and models of disease. The second point I want to cover is how do people who live in the sort of the bottom of the social hierarchy, economic hierarchy, experience these policies? And then finally, what are the implications as we move forward? So one thing is that in Bangladesh, it's in the first time of its own history that there's been such a big shutdown. So you can imagine the magnitude of how people are viewing coronavirus, COVID-19. And this is across all socioeconomic classes. And I'm going to come back to this point about stigma and fear that's much more widespread. The fear of infection, the fear of dying. With the poor, it's amplified, it's magnified. They have no social safety nets. All they have is their hands, their feet. They can work, they earn daily. As Richard was saying, and Shamika earlier, a majority of our population work and rely on daily labor. If you have a shutdown, which is restricted movement, restricted transport, shutting down educational institutions, I, as someone from a better economic background, can still sit and work at home. For many of the poorest, their entire lives have come to a halt. And the reality of this is that when we have an approach, and I agree, shutdown is not an easy decision. I don't have any easy answers, but I would say there's some moral, ethical dilemmas we're talking about here. Hunger versus health risks. Hunger versus dying. What would the poor people say if you talk to them? We did a survey of 1,306. I mean, this is longitudinal. We're going to continue this rapid assessment. They actually talk about, yes, Appa, I'm scared. I'm nervous, or, you know, and the reality is less than 38% of the 1,306 had any clear idea of the symptoms of the coronavirus. So many of them are conflating it with a cough, cold, and fever. So one of the problems with that is that there's a lot of surveillance now of each other and internalized fears of coming out with this symptom and being socially ostracized. So there's a lot of fear around what is corona, what does it mean? Against the whole backdrop of a shutdown that reinforces the message that this is a huge, huge, deadly pandemic. The reality is we don't know enough. We have low levels of testing. We've got, you know, reports of deaths that are, you know, some would argue are probably underestimated. People don't know about the comorbidities. But what I really wanted to say is that in public health, although it's changing, one of the predominant approaches is looking at individual determinants of health. And going back to that whole point about context, we can't take away the contextual realities, the structural and social inequalities of most of these individuals' lives. The rickshaw puller, the garment worker, the daily laborer, they live in conditions that don't allow them to maintain the basic precautionary guidelines, masks, social distancing. You've got 11 members of a family in one crowded room in a very crowded slum. We're one of the most densely populated countries in the world. We can get into debates, well, if we didn't have lockdown, there would be greater spread of transmission. But the reality is they have very precarious lives. And there are various kinds of social disruptions. We see violence, we see arguments, we see social unrest, particularly with relief distribution. The government has rolled out a national stimulus package with food. It's been slow to start. There are criticisms around mismanagement. There's also criticisms around food being given to all members of the communities, particularly the poor. And there's a lot of criticism that certain groups are being favored. You know, in our case studies, we found that many of them talk about where, you know, even though you have these lives in these spaces, there's now these frictions and fractures because everyone's competing for resources and now it's for food. People can't work, people are using savings, people are borrowing loans on higher credit, people are talking about the uncertainty of the lockdown, because when we first started the lockdown, it was March 26th. It was extended for 2 more weeks under it's a holiday, and now it continues to be extended. One major issue that keeps coming up is fear and stigma, and this is not just amongst the poor. We have entire streets and buildings shut down under a lockdown in many parts of Dhaka city. One person is found to be infected. So if you can imagine at the most poorest communities and settlements in poorer rural areas, this is sort of magnified and amplified. So people talked about, I try and hide my cough, or we have stories of people who fled slum settlements to go back to the village, people who fled villages. There's stories and incidences of relatives being dumped if they have suspected infection. And I think one of the real challenges is, and it's a couple, it's a very complex situation. How long can a shutdown be sustained in low-income countries while, you know, there are certain steps that need to be taken to control transmission, but how long can a lockdown be sustained when we have differential set of sort of pool of resources where most of the poor don't have safety nets and other sectors are getting increasingly affected? You know, business sectors, and what is the longer term impact? We're seeing it unfold. And, you know, one of the questions I ask myself when I read through all the transcripts and the survey materials is, what would the community say? Have we ever asked them as decision makers and policy makers? Would they say that, let me work? I'd rather choose to die, but have food in my stomach than die of an illness because everyday life is precarious. They deal with multiple challenges. Dengue is coming. You've got other kinds of health problems. You've got, children dying, infant mortality, neonatal death. You've got diarrhea. You've got all kinds of coexisting challenges. So, I mean, I think for me, one of the questions is when I do my research and I look at what the narratives are, and when I look at the surveys, some of the key takeaway is there is stigma and fear, and we need to really address this through health messaging, because the shutdown kind of reinforces that. We don't have a lot of choices, maybe. Maybe we have to take these steps because to contain transmission. At the same time, if food is not given and distributed well to farmers and the poorest, there will be starvation. If this continues for another couple of weeks or months, if this is not handled in a way that acknowledges that for the poor, health is much more broader. Health is not siloed in the way we've siloed it into biomedical disease and individuals. It's very much integrated. Health, social, economic is very much a broader broader perspective of everyday life and living. I'd like to leave you with that as my initial thoughts. Thank you.
Sabina, thank you so very much for that. We've had a huge flood of questions coming in, and there's no way at all that we're going to be able to cover them. But I wanted to actually make sure that every panelist has a chance to answer, I think, the question that Sabina posed so beautifully. And that really is, how long can we go on with a lockdown? In particular, not only balancing the potential adverse effects of a lockdown on health due to the impairment of livelihoods, but also due to other pathways. One of our participants has asked, for example, on the impact that a lockdown has on accessing routine healthcare for conditions like diabetes, cancer, and so on, which obviously when public transportation is no longer available, therefore, how do you get to the clinic for your regular visits, so on and so forth. So what the question to all the panelists, and then we'll see how many more questions I can address, is, how long do you think a lockdown should continue? And what should the government be doing in order to actually prevent what is inevitable, that is the kind of spread of the epidemic that will happen when the lockdown lifts. So just for all our participants to be on the same page, the lockdown doesn't actually demolish the virus. It isn't going to vanish. It basically delays the epidemic and slows it down, so that instead of what I'm sure everyone's heard a lot, we flatten the curve, so to speak. So the question for each of the panelists, and Richard, of course, you've also heard some specific points that Srinath had, and you're free to address them, but can I request each of you to just take 2 minutes so that we can also gather some other questions and respond to them. Richard, first to you.
One of the first edicts that we learn in medicine is, above all, do no harm. And I'm concerned that present policies, in fact, will cause far more deaths than this epidemic will cause. And I think Sabina asked the critical question: what would the community say? And for the 70 or 80 or 90%, whatever it is, that is in the informal sector, that is earning daily wages, my guess is they would say, let us go back to our life. We will try to maintain some degree of distancing. We'll wear masks when we can. We'll wash our hands whenever we can if there's water available, and so on. But let us get on with our life. And I would then, if the question you pose, how long should this go? I would say it should be lifted as soon as possible in a staged manner, but it should not go for another 2 or 3 or 4 weeks. I think that will only lead to increased overall mortality, not just mortality from COVID, but overall. So above all, we should do no harm. We should reduce our this narrative that we need to protect the tertiary facilities and deal with community-based intervention, community-based care, and not punish people for things that they now have a narrative that says we've got to be terribly afraid. This is the plague. We're going to do all sorts of terrible things to each other. So Sabina's comments were absolutely spot on. Thank you.
Thank you, Richard. Srinath, one of the things that Richard spoke about was also the focus on hospitals. And, there have been commentaries about that too, that where in a region where most deaths actually occur at home, how misplaced is this anxiety about hospitals, and should we have been focusing actually on community-based care to actually detect and manage respiratory tract infections at home? But also, please also answer my the broader question about how long the lockdown.
Vikram, firstly, I do not think the lockdown should proceed beyond what has been already extended. Secondly, even during this period, a considerable amount of differentiated implementation has been proposed. Those which do not have currently a very high caseload are able to relax many restrictions that are there even during this extended period. Agricultural operations have started. A number of informal occupations have been permitted. It is only in highly densely affected areas with high caseload that there are greater restrictions. So I believe that differentiated slowing down of the implementation of the lockdown should be there. But beyond May 3rd, I don't think we should be proceeding with a lockdown unless there are extraordinarily hot spots which need to be restricted. Secondly, regarding the question of whether we should have focused much more on primary care, yes, that has been done. For example, in Kerala and in Andhra Pradesh and Odisha, that's being done. Now, the question was, if there is a surge, and if there is, as has been even said on this panel, inevitably there will be a surge, then are we a little better prepared in terms of protecting lives of the people who are most sick? I think time has been bought for preparing a little better in terms of hospital capacity, personal protection equipment, getting more ventilators despite the huge international competition, and may I say, hijacking of supplies bought for by Indian states by some international lead OECD countries. Despite all that, I think a lot more time has been made available for preparing. But ultimately, this battle will have to be fought at the primary healthcare level. And that is where I think Kerala, Andhra Pradesh, Odisha, these are some of the states that are setting the models. They need to be emulated elsewhere as well. I fully agree, but preparing the ground, even in primary healthcare, was important. It could not have come overnight. So I think the lockdown has given an opportunity for strengthening the healthcare response at all levels, but certainly not beyond May 3rd, should the lockdown continue.
Thank you, Srinath. Let me now ask Shamika the same question as before, but Shamika, there's been also a number of questions, which again, I think we'll share with you after the seminar is over. The Mittal Institute will send the webinar questions and people can choose to maybe answer them on our website. But in addition to the general question, I wanted to also hear from you about any specific prescriptions you might have in order to mitigate the livelihood calamity that so many millions of Indian workers are facing during and in the weeks ahead. Because of course, let's not fool ourselves. The lifting of the lockdown doesn't mean everyone's job is going to miraculously come back on May the 4th, right? I mean, this is for some people a permanent end of employment for the foreseeable future. So what do you see in the context of India's economy, a kind of an essential basket of services that the government should provide, in addition to my first question about how long?
I think, Vikram, the lockdown must be lifted as soon as possible. Other than the hotspots, I think the state has the capacity to be able to manage. And that's why I think, this list of essential services is growing and is growing every day. And that's because I think there is a realization that there is a certain amount of resilience in the system. People are far more aware, and that's why I keep talking about this concept of demand elasticity for self-protection. People are not sitting ducks either. Firms are also innovating. I think one thing we have and should mention, we've forgotten to mention, is that of course this has turned into a humanitarian crisis. But the state has responded in terms of, the first set of announcements that the government at the center made, I think the second day of the lockdown, of about 1.7 lakh crores, was almost entirely focused on the bottom 2 quintiles of the population. So there were very specific packages announced in terms of construction workers, because those are usually the migrant informal workers in the cities. And those are the ones you saw the reverse exodus happen. So there is a large concentrated sort of a cash transfer and a food transfer program for construction worker. That's one. The PDS was enhanced, which is the public distribution system. That was enhanced. The self-help group women were basically were told they will get a certain amount of front-loaded, credit. The PM Kisan, which is a form of directed cash transfer, covering a very large number of farmers across the country, that was front-loaded. So there have been announcements in terms of, and these are only the central government I'm talking about. Many state governments have also announced their different complementary sort of packages. So one thing is to understand that there has been some response. Now, well, actually quite decent response, but when I say some, I'm saying we need now reverse information flow. What we need to now figure out, how is the PDS working, right? How many people have got it? So now that level of information really requires the third tier of the government. It's not just the center announcing and the states agreeing to do that, but now we are talking about local administration, block development officers, etc. At that level, now we need to start collating information to see how well is the security, the safety net, which the government has announced, how well is it percolating down to that level. But I think, and of course there is the Rabi crop, the wheat crop is standing to be harvested, and there's great sensitivity and political sensitivity around it. So that has been allowed, and therefore agriculture, I think, should be relatively unaffected. Now, I think overall, we should also see a window of opportunity in this. And I think Srinath will be very happy to hear what I have to say on this. I think health sector has the capability to do for India what the IT sector has done for the last 30 years. So, perhaps this is the time when we need to say, our next growth strategy, India's growth strategy has to be healthcare investment center. We really can grow this, big economy on the back of investments in healthcare, both public and private, because I think everyone in the country is now acutely aware of the shortages, private sector as well as public sector. So I think from an economy perspective, I really think we have to drum down this fact to all the policymakers and think of exactly now, what are those investment strategies? Can we pay our doctors twice as much so they come back to India? Can we increase the primary health centers, right? Can we improve our health IT system? Why am I still working on Johns Hopkins data, Vikram? I should be getting data from every state on a real-time basis, right? That's what investment is needed. Thank you.
So thank you, Shamika, and I'm going to ask Sabina, and then I'm going to ask you some general questions that have come. There's so many that I'm going to curate them, and I'm going to request you to put up your hand if you want to answer that. But first, Sabina, I also want to say, Sabina, I thought your remarks, about how these policies differentially affect the poor was quite timely, because I just read in the newspapers today some other commentary written by someone that wasn't it interesting that in India, when we had to get all our people back from abroad, we put on chartered flights. But for the migrant workers in India who needed to go from Delhi back to Uttar Pradesh, we stopped their trains. And it struck me that this was a kind of complete paradox. I also want to turn back in the general questions about the issue of fear and stigma. But first, what is your prescription to the issue of the next few weeks in terms of policies? And I'd like you to speak about Bangladesh.
So as I said earlier, because if there is a level of management and governance to providing food to all the poorest and most affected farmers, migrants, the poor, and you have a health sector, health system, which is robust, then a lockdown, if it goes on for longer, fine. We have reasons to understand you're trying to protect communities and everyone, and you have also a health sector that is being able to reach out and meet these needs. The reality is that that's not what's happening, right? The government has been very proactive in rolling out the stimulus package. They're working with community health workers. They're giving health messages. I think longer term, if this continues for a couple more weeks, there is going to be some very real effects economically, And also even, I mean, I was going to say, I was reading somewhere where Iran, it's battered by sanctions, is trying to look at partially lifting stage by stage their lockdown because they cannot afford to be in a continued shutdown mode. And it's unknown charted territory because the overwhelming message and model is lockdown, lockdown, lockdown. I think we won't have a choice at some point. And I think that what we need is, at least in the context of Bangladesh, is the private sector, the civil society, different actors who are quite active, but to come together and mobilize with the government, some strategy and planning, because there is going to be longer term consequences, even just with the impact of this shutdown for the last, it's almost going to be now a month next week. And I think there needs to be some real thinking around how do we do this? I mean, I don't know. I'm just an outsider coming in from a perspective of what the community is and what I see and what I hear. Yeah.
Thank you, Sabina. Now I'm going to try and ask questions. And like I said to all the panelists, if any of you would like to take that question, just show me your hand and you'd be welcome to take it on. The first question that I'm getting, and a lot of people have commented, and Sabina also mentioned this, is the issue of fear and stigma. And not just the first point is the fearful reaction when death is part of your everyday life, and then suddenly the whole country locks down because of this infection. And how do people incorporate that sense of, oh my goodness, this is going to be a much worse thing than what has always been happening for generations? And could the messaging have been done in a much more sensitive way, particularly for the large groups in our country for whom understanding this issue of risk it has to be conveyed in a very specifically clear way. Similarly, there's another question related to that about the language that has been used in the media. For example, some words that participants have mentioned are super spreaders, patient zero, and of course the most worrying of all, the human bomb, reflecting of course also the kind of tensions that are happening in our region between different communities, in this particular case in India with the Jamaat the Jamaat congregation. So I want to hear from any one of you about what is the single most important lesson you take away about future pandemics. How do we communicate information to our population in a manner that does not inspire fear, worsen stigma, discrimination, and indeed even fuel hate? I think we unfortunately lost Sabina right now, but Richard.
Well, I think that this is one of those terrible collateral damages that occur. The vast majority of people will never experience any of this illness at all. That's what the epidemiology tells us. And yet this level of fear that has percolated, and victim blaming, which of course is the very first thing that happens with any epidemic, whether it's HIV or anything else. The first thing we do is we blame the victim. It's your fault that this happened. That's been one of the terrible things that have come about because of this, particularly in South Asia. So I would say that, again, we're not supposed to harm. We're supposed to make the situation better. We're supposed to reduce mortality. And my great concern is that, in fact, if these programs continue much longer, the mortality will, in fact, increase. It's one thing to, and it's wonderful that all of these policies have come about, but the time from the policy until the food actually gets to somebody in the home will be weeks or months. If you're hungry, you want to eat today, maybe tomorrow if you're lucky. But these policies will do nothing to assuage the immediate concerns and privatization that people are facing. Let me say one other thing. I think your example of people being flown home and the migrants not receiving anything speaks to the class differences, the way this disease, in fact, has played itself out, and the way most diseases play themselves out. That is, the middle class, or those who can benefit, and those who are the vast majority are not. And that's the great tragedy with stigmatization or any of these activities. Thank you.
Shamika?
See, Vikram, this the class issue, which it is, perhaps it is a class issue, or South Asia, if anywhere, class is a very, a very real aspect of day-to-day life, but in many ways it is part of the whole world. But let me make another point. Given that all the cases that we have in India are truly imported cases, Vikram, if we had not chartered and brought these people and kept them in quarantine camps, can you imagine what would have happened? Perhaps we would be in a similar situation as Italy or the US, really, where the travel bans happened at a much advanced stage. So I do understand the fact, of course, the migrant laborers should have been provided, because you also have, infection spreading from the urban areas into rural. Now, very few cases have come up. That could again be an outcome of the testing itself, because the testing so far, we are looking for the needle where the light is, right? So we don't know what's happening in a lot of the rural areas. But I think in a hindsight, getting people from different places, airlifting, I think was one of the reasons why we were able to contain, the overall numbers. The second aspect of this is, what we have also seen in India are that health workers are being attacked and they're being driven away. Now, this is not new by any stretch of imagination. In fact, if you're familiar with Kerala, and I'm from Kerala, so I can tell you that Malappuram, for the longest time, Malappuram administration has struggled with vaccination, right? Nurses and doctors have been attacked and they've been sent away because there is fear. Now, against a vaccine, if you don't get your child vaccinated, the cost is for you and the family and the child. In these kind of infectious diseases, the negative externality is so severe that there is a community. I think that balance is very important. That's where the communication aspect comes in. It's a very important point that you're making. And I think beyond national leadership, I think this is also a time where we need community leadership and this great balance and trust, in the sense, if you do see symptoms, people should be brought out for testing. And particularly if the contact tracing, right now the Home Ministry is observing more than 30,000 people who are part of the congregation that happened in Nizamuddin. So these are real, sort of network effects that this country is dealing with. And we shouldn't, we should keep that in mind, that the costs are quite enormous.
Yeah, so Srinath, you had your hand up as well. And I also wondered whether you could take one extra comment from Shamika and Sabina, then we have to wrap up, about the role of the community. My observation over the last many weeks is that I haven't heard many civil society voices working in strong partnership with the government, but I could have missed it. And I'd like to hear your thoughts about, have we done enough to engage civil society in a collective effort, apart from just staying at home, but actually engage them as being active partners in controlling the pandemic? Srinath.
Okay, very brief comments on the three issues. Firstly, the role of the media. I think the media was substantially influenced by information flowing from abroad, seeing the experience of OECD countries getting swamped, and of course, a large number of people appearing on different TV channels saying that there will be millions of deaths in India. But even then, there should have been greater maturity in the media. I think it's also a failure of risk communication adequately by not only the government, by the various public health expertise that resides in the country. I think we should have anticipated this, and we should have actually reached out to the media. Even if certain sections of the media are immature, it is absolutely necessary that we use all channels to communicate to the people directly in a much more mature fashion. That's as far as the media is concerned. Secondly, migrants, I believe it was absolutely essential that we should have escorted them back to their places, because these are not the people who were likely to have been exposed to the first wave of virus carriers. Neither the returning travelers from abroad, nor their immediate contacts, whether it's the families or the drivers who drove them from the international airport, would have mingled with the people who were at construction sites or other low-income occupations. Their dwellings were different. They would not have carried the virus back into the villages, and we unnecessarily locked them up. And that is one area I feel we could have acted very differently if we had a mature assessment of the situation then. Third, in terms of community participation, I entirely agree that the community participation is absolutely critical. And we have seen that work to great advantage in Kerala, where the local panchayats as well as the volunteers have been taking part in contact tracing as well as in providing a lot of services. And I think that's been one remarkable partnership. But it's also happening in Andhra Pradesh, where volunteers who were earlier appointed even before this particular COVID outbreak, what are called the village and ward volunteers, who are officially appointed after being applying. They're working with the primary health care teams in order to do not only contact tracing, but also trying to do syndromic surveillance and also providing certain degree of connectivity to the overall health system for getting people checked up. I think all of these are important examples of community participation, which ought to be emulated across the whole country. I would say what we really require, if we say ICT, it is intelligent community and technology together in combination. That is my idea of ICT.
Thank you, Srinath. And the final word to Sabina, and then I'll round up.
Okay. So I just wanted to say the government is working with BRAC, which is one of the largest NGOs, to get community health workers to do appropriate health messaging and also for contact tracing, to give better information around symptom identification. About 2 weeks ago, there was a call for action by many different civil society groups and NGOs and other actors in the country. What I'd like to see more of is more mobilization across with the business, the private sector, but there has been all kinds of mobilization on the ground as people anticipate how to manage this if the community transmission increases. But yeah.
Thank you all very much. I'm afraid we run out of time, and I really want to disappoint all the many people who've got questions pending, but I'm going to figure out with the Mittal Institute if some of those questions could be sent around, and perhaps we can have an online blog. But I want to summarize what we've just heard from this amazing panel is that we don't have a choice. The lockdown must be lifted. The question of the extent to which it has impacted on the curve, there are mixed opinions of that, but I think generally there's consensus that if you keep people locked down, you will ultimately see a reduction in transmission. It goes without saying, that's the very nature of a lockdown. The question now is, where do we go from here? And I heard consensus from all four of our panelists that we need to have a clear strategy for a staggered lifting of the lockdown by focusing on real-time data from the many different clusters in our country, which could be at the level of districts, where we have a very clear strategy of counting the cases in order to inform the gradual lifting. As we lift, I think I also heard a lot about the importance of communication. I'm sorry, I can't remember Srinath's acronym. I was trying to write down intelligent and I missed the C and the T, but I'm sure, Srinath, this is one of your wonderful acronyms, but I think we got the point that intelligent and sensitive communication is a very important piece. And I think it needs to go beyond the daily briefings at the government level. I think there needs to be a much better communication of risk so that anxiety and fear about the infection can be reduced. And very importantly, the issue of stigmatizing people must be addressed head on because too much of that is already happening. The third thing I heard was very much about the need for an equity lens through which all the lockdown procedures, the lifting of the lockdown and future procedures are implemented with a particular focus on women and on the migrant and the informal economy, which of course is actually the majority of the country. And that finally, as the lockdown is lifted, I think we can all anticipate cases emerging, and therefore we need to have, hopefully use these precious few weeks in having put into place across the country a robust strategy of case finding, strengthening hospital services where needed, and also the contact tracing. In fact, I think many people mentioned the Kerala model. I'd urge everyone who is interested to know how to manage an epidemic through local action. Please do look up the extensive amount of writing on how Kerala has done this, not only for this epidemic, but also previously for Nipah many years ago. It's a textbook case on how one should, in fact, reduce the spread of an epidemic. So with that, I'd like to thank our four panelists very much. I'd like to thank the nearly 600 participants who were on the webinar, and hand over back to you, Chelsea, for your closing remarks.
Thank you.
Great, thank you. Thank you to our attendees, and a very big thank you to all of our panelists and our moderator for joining us today. Please visit our Institute's website for more information. And join us next week during the same time for our next panel, The Science Behind COVID-19. That's all for today.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you all very much, Richard, Shamika, all of you. It was terrific. It was such fun for me, and I hope you enjoyed it as much as I did. I really enjoyed that. I wish we could have more of these chats.
I want to go for another hour or two.
I know. We could have, but I want to thank you all. It was terrific. I really enjoyed it, and I know we're going to get a lot of very positive feedback. I'm already seeing a bunch of WhatsApp messages coming in from different people. So thank you all very much. Have a wonderful evening, and look forward to our next conversation. Bye-bye.
See you.
Bye-bye.
Bye-bye.